We are live, please.
Okay. Good evening, all the AIS members, and happy festivities, happy Sankranti, happy Bihu, happy Lodi to everyone. So we are at one of the most interesting webinar which AIS ARC conducts on third Friday of the month. So it is going to be on clinical record keeping. I'm really thankful to our member ARC, Dr. Deepak Mishra, for conceiving such a beautiful concept for today's webinar, monthly webinar. And without much ado, can I request Dr. Deepak Mishra, member ARC, to carry forward the proceedings?
Thank you, Prashant sir, and welcome everyone for this.
Dr. Deepak, your voice is not audible. It is cracking.
Me, along with my co-moderator, request our chairperson to say a few words. Professor Tetial.
Yeah, I think, good evening to all of you. As Dr. Prashant nicely introduced the, subject. And this is one subject, we need to really go in detail. Record keeping is one which normally gives you a very nice clinical record keeping, clinical investigative records, then your planning. And ultimately, this is going to solve your problems in a subsequent phases of patient care. Not only the post-op management, the care management, follow-up of these patients, and most importantly, it's going to safeguard you from various medical legal aspects. I think I've learned now, some of the older institutions where you have all physical file recordings, which is making life very difficult for most of us. But if you have electronic record keeping, things have become very effective. And in fact, it saves a lot of time, saves a lot of information which is needed subsequently also. And now in recent time, you'll have a AI-based record keeping clinical recordings. And that's going to be a challenge for us to learn also and be with the system which gives you a best outcome for your work in your clinic, your hospital, and your practice areas. And the topics Deepak has selected is absolutely, I think, going to give us a lot of things. And in fact, I'm going to learn so many things today. Thank you, Deepak and Prashant, for making this type of ARC program.
Thank you, sir, for your kind words. I think I would request the next chairperson, Dr. Lalit Verma, sir, if he has joined, if he can speak a few words on this topic.
Lalit Verma sir is traveling, so we
Okay,
request Professor Kamaljit Singh sir.
Nothing more to add. I would rather love to listen to the speakers. And it's just a new subject for all of us, and we are trying to learn. And since I was working in a government setup, I was not having all the kinds of physical things were there only. And now I am working in a private setup where everything is electronically done. So I'm learning, and I keep an assistant to work with. So I learn a little bit of the process that is done in this. So thank you so much, Deepak and Prashant, for making this important webinar today. Thank you.
Yes, sir. Dr. Subhash Dadia sir, your few words. Sir, you are muted.
Thank you, Dr. Prashant and Dr. Deepak. It is very good subject, and I will also be learning new things about this electronic record system because we have this physical record system, and it is very important topic for all of us. And from medical legal point of view, it is very important to maintain the records, accurate records.
Thank you, sir, for your kind words. I think we can start the session today. First up, we have Dr. Namrata Stock was supposed to be there, but I think ma'am has not joined yet. So I would like to
Madam will
invite.
be joining about half an hour later. She's
So
with
we
us.
can probably
Yes, sir.
incorporate
Yeah,
her
you
talk
go
in
ahead.
between the talks.
Correct.
Yes.
All right. So first up, I would like to invite our first speaker for the session, Dr. Deepti Joshi, ma'am. She is a renowned pediatric ophthalmologist from M. Joshi Eye Hospital, Hubli. We all know her. Topic for her talk today is medical legal aspects for pediatric surgery. Over to you, ma'am.
Thank you, Dr. Dipanshu. So at the outset, I would like to thank Prashant sir as well as Deepak sir for this wonderful opportunity. So my topic for today is medical legal aspects in a pediatric surgery. So could be pediatric cataract, pediatric squint, or even a probing. So why pediatric ophthalmology is medico-legally sensitive? Basically because a child cannot complain. Delayed presentation is very common, but then we get blamed rather than the presentation which gets delayed by the child. And the outcome is not dependent mainly only on the surgery. It also depends on the delayed presentation of the child, resulting in the amblyopia. So this is something which is not, if not discussed with parents before, I think can result in a far more disabling outcomes. In addition to that, the child cannot complain, the child cannot comprehend also. So most of the time, the outcome is not judged by the patient point of view. It is judged by the parent's point of view. If the parent's perception is not same as our perception, then if their expectation is not same as our expectation and it's not conveyed properly to them before surgery, I think that's where most of the dilemma starts. And most of these children who have underwent congenital cataract surgery or squint surgery, in the infantile squint surgery, they require a long follow-up. So over a period of time, they tend to lose their all the documents, and because of which there is a memory mismatch, and that may result in a litigation of the new doctor as well as the primary doctor over few years. Finally, the court views childhood blindness as a catastrophic injury. So the key reality is, so many times whenever we have seen, even recently, when there was a case when a child had lost, there was a loss of a child recently, the emotional aspect jumps up in case of a child more than the technical excellence. All the media jumps up. There are some child welfare society which jumps up. The NGO jumps up. So all of these people start jumping up more than that of the technical medical people jumping up into the management aspect. So the emotional harm outweighs the technical excellence. So the most important when we were talking about the record keeping is basically the consent. What court expects is that whenever there is an adult patient undergoing surgery, most of the time it's the son or the daughter who accompanies them. But when a child undergoes a surgery, the whole family comes thinking, "Arey, 1 saal ka bacche ka surgery ho raha hai, let's all of us go." So it's very important that you take a consent from the immediate legal guardian, the mother, father, rather than some other all the other the family members who are present over there. The consent should be procedure specific. So it has to be whether AIOS has written consents available for pediatric cataract, pediatric strabismus, including probing. So all of these are very specifically guided already, and it's available in the AIOS website. So next, it should be child specific. So if any child is having Down syndrome, cerebral palsy, those things have to be mentioned. The risk associated with it has to be mentioned. And specifically, all these risks have to be counseled to the parents, and these have to be documented. The most important, many times whenever there have been litigation with respect to pediatric cases, it has always been with respect to anesthesia. So the anesthesia consent also plays a very important role. So it shouldn't be a single line consent form like it's taken in case of an adult. Amblyopia, need for repeat surgery, and uncertain visual outcome has to be mentioned when you're taking a consent. So it's not just, the consent is not just a signature, it is basically a documented communication process. The whole of the communication has to be documented. So if we go case wise, so the most common thing, I would like to just highlight some 3 cases. The most common litigation in with respect to the pediatric has always happened with respect to retinopathy of prematurity. Parents say the neonatologist was more involved in protecting the child, so he becomes the savior, but then nobody told us about the eye checkup, and ophthalmologist somewhere gets blamed a lot. And court presumes that ROP blindness is preventable, and the responsibility is a shared responsibility between neonatologist and the ophthalmologist. So here comes the importance of documentation. All the ophthalmologist who does a ROP screening, a screening protocol has to be displayed. Document at what gestational age, at what post-delivery date was the child referred to you. most of the time the parents end up missing our follow-ups because they say the child was not keeping well, child is very tiny. So these missed visits has to be documented, and a parental counseling, whatever has been done, has to be documented. Similarly, cataract surgery. Parents come and say, well, my child is still not seeing after the cataract surgery. They do expect a miracle because they think it's the same as that of an adult cataract surgery. They do sometimes allege us about a false assurance of the good vision. And most of the time, the court asks us, when was the diagnosis made? What was the duration between the diagnosis and the surgery? If there was a delay, why was it? And was the amblyopia explained? So writing up this amblyopia part, the visual prognosis depends on when the child actually presented to us, the compliance with the occlusion. So post-op also the vision continues, vision development. This has to be mentioned that it has been conveyed to the parents, becomes very important with respect to congenital cataract. When you come to the strabismus aspect, parents say the child just still squinting despite the surgery. Well, most of the places strabismus is just considered as a cosmetic abnormality. And so parents do present to us very late with respect to minimum 3 to 4 years would have passed since the child would have been squinting. So the residual deviation, no improvement in vision. So it's very important. Again, we document that this is not a refractive surgery. Multiple surgery may be needed. Muscle strength is not in our hand. It's not meant to restore the vision. Patching amblyopia treatment will continue. So all these documentation, it's not just telling, it's writing it up, taking their signature, mentioning that this is the person who is signing, the father or mother, the date, and mentioning the relationship below that signature plays a very important role. And the most important consent is anesthesia. You have to make them understand anesthesia has a higher inherent role with respect to the life danger, but then it's unavoidable. So we have to be very sure with respect to the anesthetist who we select, and when you decide you want to do a pediatric surgery, the facility adequacy plays a very important role. So the defensive, there has to be a separate anesthesia consent. All the side effects of anesthesia has to be mentioned. Similarly, pediatrician consent stating that this child is fit for surgery under general anesthesia becomes very mandatory. And all the syndromic children, a risk explanation both with respect to pediatric point of view, anesthesia point of view, explain, take a consent becomes important. So documentation is what actually wins the cases. Remember, it has to be contemporaneous notes. So if at all you are giving CPR, God forbid, it has to be minute by minute, which has to be noted at that moment. It should never be a retrospective notes. That becomes very important. Consistency plays an important role. You write the child's vision as 6/60 in one visit, and then you mention it as 6/12 all of a sudden. I think that would not be accepted. And the overwritten, same using different inks, cutting it out, all these should never be done with respect to documentation. A neutral language, and don't be very emotional or defensive when we are documenting in case things go wrong. So that plays a very important role. So if it's not documented, assume that it has never happened. So despite all these things, assume we get a legal notice. I think we need not panic. We should never alter the records, collect all the documented forms. That's what we have done all these days now. Case sheet, consent sheet, counseling notes, and respond through the hospital legal cell. So that becomes a very important. So I would like to sum up that a consent form plays the most important role whenever you are talking about a pediatric child. So written statement, everything has to be written, everything has to be documented. Tracking system should be very particular. With electronic EMR tracking systems available, things are becoming more and more easier nowadays. Follow-up has to be documented. In fact, if a patient doesn't come on the same day or the day in which you had called him, it would be advisable, open and write that the patient was supposed to come back today. He did not come back for a follow-up. It's always safe. Adequate counseling is important. So I would like to sum up by telling that pediatric ophthalmology does not fail in court because of bad surgery. It fails because of emotions, expectations, unmet timelines, and documentation from us ophthalmologists. So with this, I would like to sum up my talk. Thank you.
Thank you so much, ma'am. That was a very informative presentation. I would like to request Dr. Parikshit Gogate sir, who is the director at Gogate Eye Clinic, Pune, to discuss the case medico-legal aspects of in pediatric population. Dr. Parikshit sir, are you there?
He's there, but then I think
I'll
he's
give him a
then
call.
he's
I am very much here. Yeah.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening. Good evening. I heard Dr. T's talk, and the thing that it is emotions and expectations. That is what actually trump us ophthalmologist. So yes, good record keeping is a must. And another very valid point she made is if patients don't turn up for a follow-up, we should record that too. Now, most of us don't do that. So especially where medico-legal implications are there in ROPs or post-surgeries, because sometimes patient undergoes a surgery, comes the first day, and then comes directly 2 years later saying, no, my eye is still squinting, or I'm not seeing from that eye well. So, but then onus is also on us to see that on discharge, we insist that the patient should come for at least 3 follow-ups or at least the 1 week follow-up before we say we can promise you anything.
I'd like to add something in that.
Yes, sir.
Yes, sir.
Because, some of the kids, we are operating under anesthesia. The findings, is totally different. What you see outside without anesthesia, child don't open their eyes. I think she covered this part also. But that sometimes, it is important to record all surgeries. Maybe if something is grossly being changed, your plan, because of new findings. So maybe, one of the parent can be invited inside after changing and shown them, this is the picture. And that's why we are changing our, line of management, which is, going to save us, especially ROP surgeries. Sometimes, things can be totally different. Injuries, in pediatric injuries, I've seen that, when you see the patient outside with the torchlight because they don't open eyes, you just see a lid injury only. Once you take the patient to repair the lid injury, you see the entire globe is also damaged. And parents say, what is this? You said only lid injury and you are saying now globe injury. So those things I think is a very important part for we to understand and record those carefully. Maybe possibly take photographs and video recordings, and that will save the day, Thank you.
Thank
Very
you, sir.
valid point, sir. I think in the recent time, there is a rise seen in the ROP litigations recently, and the amount also is in crores. The latest I heard it was 1.8 CR for a case that was filed against the ophthalmologist as well as the neonatologist. And the amount was 1.8 CR because that led to important is documentation. Referral is very important because half the time patients are not referred only in time, and they present only 3 to 4 months of age when it's already late. I would request any other chairperson if they would like to comment on this. Dr. Subhash, sir.
I think in squint surgery, we must mention about undercorrection, overcorrections, and diplopia.
Yes, sir.
Yes, sir. Litigations usually which are filed in pediatric surgeries are probably anesthesia related.
Anesthesia related, very true.
Because of the deaths that occur following that. Anything from Parikshit, sir? Anything else?
No, sir, I think it's just that documentation is very important, and taking the patient into confidence, taking the parents into confidence, explaining them what is being done, and not just explaining them, documenting them. So as Titiar sir said, that perhaps taking a video perhaps also may have be needed, and then not just taking a video, but also storing a video. So, but I don't know how, to what extent that will go. But documentation is the key, without doubt.
And
Yes.
one important point is basically in this consent, other than the parents, guardians, it must be witnessed by doctor and nearby patients.
Yes.
Thank you, sir. Can we move on to the next speaker?
Then we can. Thank you,
So
Deepti
the
ma'am.
next speaker is Dr. Madhu Udiraju, sir. Sir is the director at Sri Kiran Institute of Ophthalmology, Kakinada, and he is going to present a medico-legal aspect in cataract surgery. Over to you, sir.
Am I audible?
Yes, sir.
Yes, sir.
Okay, thank you. I thank Deepak sir and team ARC for giving me this opportunity. I think in the next few minutes, I'll try to cover the medico-legal aspects of cataract surgery. That's the most common surgery that we all ophthalmologists perform. So the scope of this talk would be under the following headings: the background, the steps in pre-op, post-op, intra-op, and medico-legal aspects. So coming to background, I think the most common thing is the communication. So I think the phrases that we should avoid while we are counseling for cataract surgery, either the surgeons or in the counseling team, that it is a simple surgery, a matter of 10 minutes, pretty straightforward. You can go back to work simply. Your post-op crate is simple, no help. So I think these kind of phrases should not be used, because God forbid you have a complication later, these same phrases will be used against you in the court of law. So these things should be avoided, and it should be given the due importance of any other surgery that we do. And patient should decide by himself that he should get the surgery done, and it should not be pressurized, or the decision making should not be fastened by us until unless it's really an emergency like a phacomorphic glaucoma or something like that. But otherwise, I think even if it's a mature cataract, there is no harm in giving patient sufficient time, like 2-3 weeks time, to take the decision, come back by himself and volunteer for surgery, rather than you pushing him for surgery. That again can go against you in the court if at all you have any complications. So, and also it should be, though it is a very simple surgery, like a routine surgery that we do, all the possible complications should be clearly enumerated in the consent and also discussed with the patient, irrespective of the complexity. So coming to pre-op, there are certain systemic investigations that you need in elderly patients, like your cardiac clearance, if they're on blood thinners, whether you want to stop them, uncontrolled hypertension, breathing issues, general anesthesia, and all these cases. And in ophthalmic investigations, I think apart from your comprehensive ophthalmic evaluation, we need to do a good biometry, at least 3 readings with 2 machines with 2 different persons. OCT is mandatory. Specular microscope also we do routinely. And in all mature cataracts, you also do your B scan. And as a dictum, we always do it for both the eyes, so that you can pick up any changes that are there in one eye. That is how you have to follow. Next is identification of high-risk cases, especially mature cases, pseudoexfoliation, small pupils, floppy iris, complicated cataracts, compromised corneal clarity, one-eyed patients, pre-existing glaucoma and retinal pathologies, and diabetic retinopathy. We usually you don't limit ourselves to a written consent. We also take a video consent with the patient's blood relation, and the doctor explaining to the patient what are the possible risks that the patient can have while undergoing the surgery. Video consent has the highest form of acceptance in court, because written consents, they may tell that the patient was forced to do a written consent, but whereas in video consent, you're clearly explaining everything to the patient in front of the patient along with a blood relative, and the doctor is doing that. So I think that will hold very good value in cases of a case where you know the risk is higher. Coming to anesthesia, you usually leave it to patient's choice. You don't give by default topical to all the cases. If patient is not comfortable with topical, you can always choose subtenons, and even on bed, if it is uncooperative, you can always shift him to subtenons. And whenever there are ocular comorbidities, like when you need to use a pupil expander or is a difficult case, there is no need of taking it into the ego. Avoid topical surgery. Go for a good block, so that at least one part of the movement is taken care and you can do the surgery with a better concentration. There should always be a separate consent for anesthesia and type of anesthesia. GA is usually preferred in children and mentally unstable patients. And sometimes in mentally unstable patients, you also have to take a consent for bilateral cataract surgery or a sequential bilateral cataract surgery, because you don't want them to go through this process twice. If the patients are okay with it, you can go for a bilateral surgery also. Anesthetic backup for regular cases is now mandated by NABH, and it is up to you to implement it. And usually all the vitals are monitored throughout the surgery, even for regular cases, if you are an NABH accredited institution. Coming to intraoperatively, we should avoid any kind of irrelevant banter in the OT. Because the patient is very attentive to the conversation between you and your staff. So there should be no untoward comments like, "Oh, nahi aaya, ye nahi aaya," like anything that you're not happy with. Be sure that you don't shout and create a scene there, because the patient will be thinking that has something to do with his surgery. And in case there are any complications later, he may attribute that banter telling that there was some issue during the surgery. And always take the patient into confidence in change of a plan or inform attenders whenever it is under topical anesthesia. And I usually tend to disclose the complication, even if it's a PCR, and even if I manage to put a lens, I usually tell the complication right at the end of the surgery itself. I never hide or delay the communication. So it's a honest and early communication, which is important. FAQ also is best managed in the same sitting. I usually don't take the patient for a secondary sitting for secondary IOL, because I have a retina backup. I try to do the secondary IOL in the same sitting after explaining the situation to the patient and attenders outside. In mature cataracts, you can also go ahead and do a retinal evaluation on table, because you don't have access to it preoperatively. Coming to post-op counseling is very important. Compliance to medication is important. Immediate referral of complications that you are not able to handle is equally important. Thorough retinal evaluations in previous mature cataracts are important. If you have a refractive surprise and if it's early, go for an early IOL exchange, or you can go for a surface ablation or a piggyback IOL. These options also should be discussed in the consent form, especially in very high myopes or very short eyes or astigmatism, especially post-RK cases where the outcomes are not very predictable. I think in these cases, you should be prepared for this kind of scenarios. And just to add to what Deepti ma'am had told, there are only 4 aspects in any medical legal thing: documentation, communication, documentation of communication, and communication of documentation. Once all these 4 things are in place, I think it's mostly sorted out in the court of law. So coming to medical legal aspects, I think consent forms written is what we take regularly. Video, I have already told you, we take it in high risk and pediatric cases also. And also we take the consents that we video record all the surgeries, their medical record, investigations for presenting in conferences. I think nowadays there is also this social media and reels. Some of the doctors are sharing there also. In case you want to go ahead and do it, I think you should have a consent in which it should be included that you're going to use it for those purposes. Surgical video recording, because ours is a teaching institute, we record all our surgeries, and especially complications, we keep it for some time so that we can have it as a backup whenever we are doing in the future. And consumables also, though it is the responsibility of the supplier to give us sterile supplies, but still we don't want to take that risk. So any new batch of Visco, BSS, Trypan Blue, pilocarpine, atropine, anything that goes into the eye, we keep that batch in the pharmacy first, then send a sample from each batch for a clearance from batch clearance from the NABL lab. Once we get that document and that document is filed into our NABH documents, only then these batches go into the OT store for utilization. Again, you should have all your validated OT reports, air, water, microbiological clearance on a regular basis. So whenever a case happens, I think these will come in a very handy for you. Your sterilization reports, like your batch monitoring, individual set documentation, should also be stick to the OT registers along with the IOL stickers. Then that will be, everything documentation will be well in place. Thank you. Thank you for your time and attention.
Thank you so much, sir, for explaining the medico-legal aspects when it comes to cataract surgery. I would now like to invite Dr. Harshul Tak, sir. Sir is the director at Rawat Eye and Phaco Surgery Center, Jaipur, and also the Honorary General Secretary of Rajasthan Ophthalmological Society.
Thank you so much, Dr. Lipi. And I think Dr. Madhu has very nicely covered this entire topic, medico-legal aspect of cataract surgery. So as Dr. Madhu mentioned, and what came out from his talk is, of course, we should communicate whatever is there to the patient. That is the key. Believe me, in 22 years of my practice, I have also felt that if we honestly communicate to patient, they believe us. And second thing is, what is expected as a cataract surgeon from you is the standard of care which is needed from you in cases, especially in complicated cases. Like if you have a posterior polar cataract, of course, you need to explain to the patient about all the risk involved in the case. He may need a vitreoretinal surgeon intervention. If like we also have backup, so we keep our VR surgeon ready. As Madhu also mentioned, they have VR backup. If you don't have VR backup, you may need to send the patient at the same time or maybe at a later date. But what is needed and expected from you is, of course, not to complicate further. So having a PCR in a PPC or as such in any case is not a problem. Problem arises when you try to scoop out the thing, when you try to mishandle vitreous. So then all these complications arises. So if you handle each and every case carefully, I don't think you can land up in problem. Suppose we have, and second thing, what Madhu also mentioned, we should not trivialize our cataract surgery. That any case comes, we say just 5 minutes, don't worry, everything will be fine. No, it won't be. So whenever a patient come to me with white cataracts, with intumescent cataract, with mature hard cataract, I know we can handle whatever case. But first statement is, oh my God, what you have done? You come so late. So patient should know that no, he has come late and there are risks involved in this particular case. Now intumescent cataract is there and you have planned trifocal lenses, you have planned best of the lenses and your Rexis goes out. What are you gonna do? So they should know the risk involved in each and every case. And I think other thing is, which is important, which I recently came to know myself, is that the pre-printed consent doesn't have any validity in court of law. I'm not sure if everybody is taking, a handwritten consent for each and every case because of busy practices everyone has. I'd like to take opinion of Tityal sir also and Namrata ma'am also, whether pre-printed, because we also are using pre-printed consent forms which have been given by AIOS. So that I'd like to ask Dr. Tityal sir. Or anybody has, Madhu, what is?
Sir, we are using pre-printed only, sir, but for high-risk cases, we have the video consent bite. Video consent has the highest standing in the court, sir.
May I suggest something?
Yes, sir.
Yes, sir, please.
You see, there are two things. If all these patients are elderly, and a record of fundus photograph or OCT is very essential these days, especially when you are doing a case which is having involvement of trifocal lenses or maybe high-end lenses. So there you have to have a very good consent and all the record should be there. And specular should also be done in case you feel that there is need.
Yes, sir,
because these things would definitely tell you the post-operative. Because many a time these patients come and they say that why didn't you tell us that there was drusen in the fundus? So good indirect ophthalmoscopy and the report should be mentioned in the file, and the OCT and specular. These two things I would like to add. And many a time the counselors suggest the IOL. These days ophthalmologists are not doing the job. They are being shifted to counselors, and they always, like today only, I had a case who was implanted a Technis IOL somewhere. So that patient came to me and the counselor told a more expensive IOL. And she wanted that the expensive IOL should be put. So the final decision should be of the ophthalmologist, and you should mention it, this lens has to be implanted. These 3-4 things are there that has to be taken care of. Thank you.
Dr. Lippi, it was excellent talk by Dr. Madhu, but I would like to add 3 or 4 things. One is surgery without adequate workup is deficiency of service in court of law. So
yes,
we should, there is no harm in over investigating, but it should not be underestimated. Secondly, delay in diagnosis of cases like endophthalmitis has high medico-legal risk. And thirdly, delay in referral has also high medico-legal case risk. And the consent should be ideally in patient's language. These are 3-4 points which I would like to add.
Yes, sir.
Thank you, sir.
Thank you, sir. Very valid point from both the discussant and chairperson. One of the point I would like to mention that the urge of putting in IOL, as sir said, we should not complicate it further. The urge of putting in IOL should not be there if you don't have an VR backup. I have seen a lot of patients where IOL drop is a very common thing which we come across. And in a very tricky case, I saw the IOL. I'm a VR surgeon in Indore. So I saw an IOL drop. I went in, and as I went further for past planar vitrectomy, I saw there was another IOL which was hanging inside the vitreous cavity in the inferior retina. So the urge of putting an IOL should not be there. If you have complicated the case and you know there is no backup, then it's better to accept the point and probably refer the case. If there are no more points to be made, I think can we move on to the next speaker?
Yes.
I think we can take Dr. Namrata Sharma, ma'am.
Namrata ma'am is here. So ma'am.
Good evening, ma'am.
Good evening. Good evening.
So next up, we have Dr. Namrata Sharma, ma'am. Ma'am needs no introduction. The topic for today's talk for ma'am is medical legal cases handling a comprehensive approach. Over to you, ma'am.
Thank you. And I would like to thank the ARC and particularly Dr. Prashant Bhavankule and Dr. Deepak Mishra for making me a part of this very important webinar on a extremely important topic and something which is again not taught in the books, but all of us require to know. And I would be talking to you about medical legal case handling, a comprehensive approach. Now, why medical legal preparedness matters in ophthalmology, mainly because of the increasing patient awareness and litigation. And ophthalmology involves high volume, outcome sensitive procedures, and even routine surgeries can become medical legal cases. And proper handling generally protects not only the patient rights, but also doctors' integrity and institutional credibility. Now, what is a medical legal case? If you say in medical legal terms, it refers to any medical encounter in which the care provided is likely to be examined under legal authority to determine responsibility, accountability, or adherence to standard of care. And medical facts intersect with the legal evaluation, so one has to be careful about this. And clinical judgment may be reviewed by courts, consumer forums, or regulatory bodies. And I think that is something which all of us should remember. And documentation becomes the legal record. So what actually our residents and fellows are working is not a documentation or a hospital record, but is actually a legal record and not merely a clinical note. And that is something we should emphasize on all the people who are working up the cases. So an MLC is identified not by intent, but by the possibility of a legal scrutiny. When does a case become a medical legal case? So a clinical case may acquire medical legal status due to adverse or unexpected outcome, allegation of medical negligence or deficiency of service, disputes related to informed consent, inadequate, missing or inconsistent documentation, and patient or family dissatisfaction leading to legal complaints. Sometimes even when the outcomes are good, this may still be there. But one should understand that not all complications are negligence, and keeping that in mind, we should work up our cases and do the cases. So the pillars of the medical legal safety are ethical clinical practice, robust documentation, informed consent, effective communication, and timely escalation and transparency. Clinical documentation is the backbone and it forms the foundation of a safe medical practice and medical legal defense. And in legal review, the medical records are treated as primary and the most reliable evidence of care provided. Whatever you may tell them verbally actually doesn't hold that much of weightage as compared to what is written in the documents. And everything that is not documented did not happen. So documentation is very critical. And like I said earlier, medical records are actually legal documents. They reflect the clinical reasoning and decision-making process, establish adherence to standard of care, and protect both the patient rights and the doctor accountability. And what is not documented is presumed not to have been done. The essentials of good clinical documentation are following. That is, they should be accurate, that means factually correct, objective and consistent, legible, that means readable and understandable. They should be timely, that means they should be recorded contemporaneously with care. Anything that has to be recorded before should not be recorded later. They should be complete, which includes the examination, diagnosis, plan and follow-up, as was also emphasized by Dr. Subhash Dadia just now, that even the pre-op workup is very important, that should be documented. It should be unaltered, that means there should be no overwriting, backdating or retrospective entries. And what is must for a clear document is clinical findings and diagnosis, risk-benefit discussions and consent, treatment decisions and alternatives, and post-procedure advice and follow-up instructions. Courts generally rely more on written records than on verbal explanations which are given later. I think the most important thing, which also has been highlighted by Dr. Madhu, is the consent, which is more than a signature. And informed consent is a continuous communication process, that not merely a signed form, and it reflects the respect for patient autonomy, and it is the cornerstone of ethical and legal medical practice. The key concepts are that the consent should be informed, voluntary, and competent. The patient should understand the nature of the disease, the purpose of the procedure, expected outcomes and limitations, and consent demonstrates the shared decision-making and not defensive practice. So a signature validates the discussion, but it does not replace the discussion. So the discussion and the communication is a must, and the contents of that also should be documented. Now, what are the elements of valid and defensible consent? For consent to be legally sustainable, it must include documentation of diagnosis and indication, available alternatives, including non-intervention, risk and complications, that too in common layman language. So you have to say that the complication of endophthalmitis, it should be, 1 in 1 lakh or 1 in 10 lakh population, whatever the figure is, so that the patient understands what we are talking about. Also, the prognosis should be explained and the possibility of suboptimal outcome. There should be opportunity for questions and clarification, and special attention is required in pediatric patients where the parent or the legal guardian consent is important, in one-eyed patients and patients of high risk or elective procedures, for instance, the refractive surgery. Now, communication for us is the strongest shield, and effective communication is the most powerful preventive tool against medical legal disputes, because it builds trust, transparency, and realistic expectations, even when the outcomes are not favorable. And it really makes a difference because it reduces the misunderstanding and the dissatisfaction, aligns the patient expectations with the clinical reality, demonstrates empathy and professionalism. That is what we are supposed to do, protects the doctor when complications do occur. And it is generally said that the patients sue you less often when they feel heard, informed, and respected. Now, the elements of effective and defensible communication are that the nature of the disease, the treatment plan, the expected outcomes, the possible complications should be told to the patient. It should be free from overassurance or guarantees. It should be tailored to patient understanding, and it should be documented, whatever you've told the patient. One should avoid technical jargon without explanation, and also defensive or dismissive language should be avoided. And promising a perfect outcome should also be avoided. Now, handling of an adverse outcome should be the first response. So an adverse outcome should be taken as a clinical event, and not a verdict of negligence. And an ophthalmologist's initial response determines both the patient trust and the medical legal trajectory. So the immediate principles when an adverse outcome happens is that one should stay calm, professional, and empathetic, and prioritize patient safety and ongoing care, and of course communicate with the patient that an untoward event has occurred, and maintain dignity and transparency in all interactions. How you respond to after an adverse outcome matters more than the outcome itself. There are certain do's and don'ts of an adverse outcome. One is that one should be honest and deal with it compassionately. Document the events, like I said earlier, chronologically and contemporaneously. That means if the consent form has to be taken first, it has to be taken first and not later on. Follow the standard protocols for investigation and management. And sometimes there can be emergency situation when you have to take a different kind of a consent. So in that case, even before taking up in the surgery what you have not told the patient, it is best to take the consent first, inform the patient about it, and then do it. Don't alter, rewrite, or backdate the records. Do not make speculative or defensive statements, and do not blame colleagues, staff, or systems. I think that is the most important thing. And do not avoid the patient or the family's questions or the queries. So I think the importance of documentation cannot be highlighted more. The documentation must include everything, including the discussions which are held with the patient or with the family, and also the follow-up plans and the monitoring advice. And it should be fact-based and truthful, and it should be free from emotional reactions or assumption, and it should be focused on what happened, what is being done, and what comes next. Of course, transparency will protect credibility, and of course, concealment will invite litigation. So it is best to tell the patient everything. Now, one should be very careful when dealing with children, and there are some key medico-legal concerns, especially because the care carries the heightened medico-legal sensitivity because of the fact that parents are involved in the decision making, and the informed consent should be obtained from the parents or from the legal guardians. Again, it should clearly document diagnosis and indication for intervention, visual prognosis, need for long-term follow-up, and we know that when a particular intervention was not done for a patient, there have been litigations, and people have had to pay from their pockets. Also, which doesn't come in our purview, but comes in the purview of the anesthetist. Anesthesia-related risks also should be explained. And all counseling and discussion should be clearly documented. Now, I think when children are concerned, courts are especially sensitive, and they do assess whether care was appropriate, timely, and in the child's best interest, and not whether the vision was fully restored or not. Again, cataract surgery, because of the fact that we do it in such large numbers, because of the fact that patient has high expectations, and because of the fact that we may have to do it bilaterally, is also the surgery where litigations will occur most, especially because if the patients have unrealistic expectations in terms of visual outcome, or if you've done the surgery bilateral, then sequential versus simultaneous complications that may occur therefrom. Then premium IOLs related dissatisfaction, which may be whether multifocal or toric lenses. Then errors in calculation of the IOL power, and also the post-op complications which are inadequately explained preoperatively. So I think it is important to preoperatively only focus on these points and counsel the patient and record all the methods by which the IOL power has been calculated. All the ocular comorbidities should be looked at and clearly explain to the patients the complications and the negligence. I think refractive surgery is again an area where there is a zero error zone, and it is an elective procedure. It is a cosmetic procedure, although it is therapeutic also. So expectation is much high, and you're dealing with a younger patient. So it has the highest medico-legal scrutiny, and patients seek perfect vision rather than improvement in these cases. So because of this, again, the litigations are much more, and patients should be told about the residual refractive error, glare, halos, or regression, and any mismatch between the promised and the achievable outcomes. The mandatory medico-legal safeguards are that thorough documentation of the pre-op evaluation and eligibility should be done. The need for enhancement or the need for spectacle should be told to the patient, and procedure-specific informed consent should be recorded very clearly. Because in refractive surgery, dissatisfaction is often litigated as negligence when it is not. It is related more to the procedure than to the negligence, and also related more to the counseling. So counseling and documentation both are non-negotiable as far as the refractive surgery is concerned. Just to conclude, I would like to say that there is an important role of institute as far as the team and the institute is concerned, as far as the medico-legal liability is concerned. And it is a system responsibility as well, especially for the institutes and the medical colleges or the hospitals. And institutions and healthcare teams, they play a very crucial role in preventing, managing, and mitigating this medico-legal risk. So the key institutional responsibilities are that there should be established SOPs which should be enforced, ensure credentialing and privileging of these clinicians, and maintain the fact that incidents have to be reported, and there should be robust audit systems. Also, institutions should provide legal and administrative support during adverse events and promote multidisciplinary decision-making especially for complex cases. So the key take-home points are that good clinical practice is the strongest medico-legal defense that one can have. Documentation is the evidence. So it has to be done keeping in mind that it is a legal record. Informed consent is a process and it is not just a formality. And like Dr. Madhu said, perhaps video informed consent is the way to go, although it is not mandatory. Effective communication does reduce disputes more than technical perfections, and complications are acceptable, but negligence is not. And early escalation and transparency will protect both patient and doctor, and institutional systems and teamwork matter as much as the individual skill does. So one has to pay attention to these points. I conclude with the AIOS consent books, although they are printed, they were only taken as templates on which people can work on. And this was translated to begin with, it was in English, and then we translated in 15 languages to cover across all the states, and the translated versions are also available on the AIOS website. So thank you very much for your kind attention, and I would like to invite everybody to AIOC 2026 Jaipur, where Professor Tetial is going to be taking up as the president of AIOS. And I would also request for Chairman Scientific Committee, support for Chairman Scientific Committee in the forthcoming elections. Thank you so much for your attention.
Thank you, ma'am, for the wonderful talk. Almost you have covered each and every point. And we first invite Dr. Lalit sir's comment on the talk and that few words related to topic. Dr. Lalit sir.
Sir is not there, I think.
No, sir is there. He just lost. Okay. Professor Tetial sir.
Can you speak? Can you hear? Can you hear?
Yes, yes, sir. Yes, sir.
Yes.
Sorry for joining late. I did enjoy Namrata's talk. But you see, a lot of thing is theory. You see, we talk of, consent, documentation. But believe me, Tetial would agree and a lot of other people who are there in the panel. One thing is theory, other thing is practical. So ideally, what Namrata said should be done. Whether it is being done, because consent and document generally left to counselors and fellows. And honestly speaking, I'm a part of the same system that we sometimes only in high risk cases, I will definitely go and talk to the patient. But generally, once jab sign ho rahe hota na consent वगैरह, tab the consultant is not there. But I agree what Namrata said in Saransh, that documentation is so important, and only this can save you in the court of law. Believe me, everything you do, please communicate to the patient and relatives, and also write down on the prescription in the record file. You may be wrong. You see, sometimes you may be wrong in your diagnosis or sometimes treatment, and your treatment may not be the best in the world. It may not be the latest in the world. But believe me, court also wants you to be not, you to be an average clinician. It's not necessary that whatever Tetial does, Namrata also has to do the same thing. So court just wants you to be an average clinician. And as long as you are following some kind of protocols and systems which an average ophthalmologist should be doing, they don't care so much. As long as you have documented, talk to the patient, done in the best interest of patient. Believe me, even phthisis bulbi, post endophthalmitis, courts have not awarded punishment even if PL negative ho jaye, as long as you have done your best within your knowledge and within your purview. So documentation, I agree, Namrata, is the central part. The other thing is, which I thought must have been spoken before or not, for how long to have these records available within your practice. Because see, there are, I think, guidelines available with DGHS as well as with Medical Council of India that I think 5 years आपको record रखना है. 5
years, sir.
It is, sir, 3 years.
3 years for indoor patients.
Sorry, basically for outdoor patients, 3 years, indoor 3 to 5, MLC till the disposal of case.
That is correct, but for children, I think you have to do it longer.
Till the child
18
attains
years of age.
maturity.
So
18
that I
years of
think should
age.
be re-emphasized that ये 3-5 और बच्चों में थोड़ा ज़्यादा आपको रखना है, because till the time like Namrata was saying, most of the consent has been by parents. And other thing is for what is the validity today, because most of us are on EMR or this thing. What is the validity? I have questioned a lot of time by all of us are shifting to EMR and EHR, but that particular aspect I think needs to be discussed, whether it is admissible in the court of law or not, because that is that can be changed in your own system. And I also agree that not documented means not done. This should be re-emphasized again and again. अगर document नहीं किया, जैसे I have given intravitreal vancomycin and ceftazidime, but मैंने लिखा नहीं है, and patient landed in problem, so that means not done. And these are, what Namrata spoke and what we are talking, these are general medico-legal aspects for safe and good practices. But there may be some specific, medico-legal aspects for cataract, because, I saw 6-7 talks there, medico-legal aspects of cataract, glaucoma, retina. But most of this, what we have spoken, they hold true for all these specialties. Maybe we'll learn in this webinar, is there any specific thing involved in glaucoma, retina, or plasty? But I think this is a well-conceived webinar. Should thank our chairman ARC Prashant for his, for his meticulous planning and implementation of so many ARC activities which he's been doing, and also the moderators Deepak and Dr. Lipi Dipanshu, and all these six speakers and discussants. All of them are big names in Indian ophthalmology, and I'm sure all of them will share their experiences. Deepak, thanks a lot for having me here, and wish you all the very best.
Thank you, Namrata ma'am and Lalit Verma sir, for the saransh of the session. If any other chairperson would like to comment, or if we can proceed to the next talk.
It was an excellent talk by Dr. Namrata ma'am and excellent comments by Dr. Lalit sir. One thing is, court wants you follow the prescribed accepted procedure.
Yeah.
That has to be taken care, and we should not guarantee the patients. These are the two very important aspects.
Subhash, in this context, I think always under promise and over deliver.
Yes, sir. Yes, sir. Yes.
I would simply like to say that there have been instances where I have been in trouble, and I had an endophthalmitis, and lots of complications occur, and even expulsive has occurred. But if you keep on reassuring the patient and keep telling him and refer the patient timely, the timely referral is very, very important. What you cannot do should not be delayed. It should be referred to the better person, and a second opinion is a must. Always take a second or third opinion and mention it, so that the patient knows that there is some problem and doctor is taking all the care. So if that is there, like I had to take my patients to Delhi at many a times, and Lalit saved my life. So many a time it happens, and you have to be very, very careful and always take a second opinion if you are in trouble.
Excellent.
That is what
KJ, very well said. I would just add one line in this, and also never do bad mouthing about your colleagues.
Yeah.
Yes, sir.
Namrata ma'am, I wanted to know if video recording is actually mandatory or not mandatory. Madhu said that informed consent is not applicable in the law in the court, and he said that video recording is must, but you said video recording is not a must. So can you clear that doubt about video recording?
I think
Video
yes.
video recording is the best form of consent.
No, sir. Actually, I also spoke to advocate. Then what they said is that if you are recording, it must be submitted before 5 p.m. in court. Otherwise, it's not valid. It can be tampered with. Then it has to go through forensics and all those things to prove that yes, no tampering has been done. So the written consent and what we were talking, and I spoke again just now, is that consent first thing. If it's pre-printed, then patient, their relatives should write themselves that we have been told about all these things we have read and we are signing after reading all this.
In their own language, that is very important. If you are taking
whatever they write themselves in their
themselves
handwriting,
and in the writing,
and then they
which,
sign.
In the language
And
which they understand.
doctor or any doctor of his team only has to take consent.
Another important thing is that the consent should be taken 2 days prior, they say. It's the same day the patient comes and we take the consent. Then if the patient says in the court that they hurriedly asked me to sign and I signed and I have not even read.
नहीं केजे उसमें पता क्या है, अगर वो पेशेंट खुद लिख रहा है ना, like Harshil was saying, if he's writing with his hand, अपना पेन पकड़ के लिख रहा है ना, तो I think it's okay.
इम्पोर्टेंट है.
Yes.
और अगर पहले ले ली जाए तो और इम्पोर्टेंट है, क्योंकि सर्जरी के वक्त लेते हैं ना, जैसे हम लोग सर्जरी के वक्त ले.
So that what court says is that is the ideal condition, that you are given consent 2 days, 3 days before, so that they can read all those pros and cons and of whatever is there. So that is ideal. But
yes.
Chalo.
That's great. I think the talks are finished or what? Thank you so much. Thank you all.
No, sir, we have a few more talks to go.
Okay, fine. So you proceed further.
Yeah, so for the next talk, I would like to request and welcome Dr. Purvi Bhagat ma'am. She is an ophthalmologist and also an educator, and she is a renowned ophthalmologist from RIU Ahmedabad. Madam is going to speak on medico-legal aspects around glaucoma surgeries. Over to you, ma'am.
Yeah, thank you so much, Dr. Dipanshu, and thanks to Team ARC for this webinar and for including me in this webinar to talk on medico-legal aspects around glaucoma surgeries. So why glaucoma surgeries are specially medico-legally sensitive? One is because many of the times we are doing surgery on potentially asymptomatic eyes. We all know that glaucoma is a silent thief of sight. POAG does not cause symptoms till the very advanced stages. But many a times surgery and other procedures are performed when the patients still don't have the symptoms. Second is the outcomes in glaucoma surgeries are quite unpredictable. They are probabilistic and not very definitive. They are very unlike cataract surgeries and glaucoma surgeries when you yourselves to a great extent know what you're going to see the next day on the slit lamp. There is a risk of irreversible vision loss. The disease itself can cause vision loss, and the surgeries that we do for these patients also have the risk of vision loss. Long-term follow-up are always in disputes because it is very, very difficult to make the patients understand and be compliant with follow-ups even after you have done a good surgery. And of course, there is an increasing surgical complexity because each patient's clinical profile is different, ocular surface which responds, the healing process is different, and their systemic profile is different. And all these problems put together, they are cumulative in children, and where not only the glaucoma surgery, but maybe they need keratoplasty in future, they need visual rehabilitation, and so much more was described by Dr. Deepti. So everything just adds up when we are operating on children. And of course, the day-to-day rising patient expectations and the expanding medico-legal scrutinies. So what is the standard of care that we need to practice? So first of all, whatever surgery we do, it must be indicated and it must be justified. If you are doing a TRAB, why are you doing the TRAB? So this decision has to be based on the disease severity, the target IOP rationale, or it could be a documented progression evidence and other factors like the patient is not compliant to treatment or the patient is sensitive to and has multiple adverse reactions to drugs. So all those things have to be documented, that why are you operating the patient and what is it that has led you to do the surgery. So any deviation from standard practice has to be defensible, and all your records should reflect your clinical reasoning and judgment. That is, what is the reason that you have taken that subsequent step? And it should not be just a conclusion that advise surgery, but why are you advising surgery? What is it that is making you take that decision needs to be very clearly documented. And informed consent, we all have now agreed that it is the cornerstone of defense. As far as glaucoma surgeries go, the consent must be procedure specific. A consent for TRAB will not do for a surgery done through MIGS, and even in MIGS, a surgery for an eye stent would be different, for a GAT would be different, for a KTB would be different. And that those consents are again not equivalent to a consent taken for a tube surgery. So each has to be customized and personalized. According to the surgery, again, the risks have to be mentioned. Suppose you are doing a TRAB, then the risk of failure, the risk of hypotony and maculopathy and vision loss, the vision loss that may occur because of a wipeout, the need for resurgeries, reinterventions, all those things have to be mentioned. The benefits, of course, have to be mentioned. And if there are any alternatives to treatment, they have to be mentioned and discussed. Like the scope of maybe further adding up the medications, maybe the scope of SLT or some other surgeries, they need to be discussed in the consent. An additional enhanced consent has to be taken if you are operating a one-eyed patient. If you are operating an advanced glaucoma, especially those which have split fixation because of the risk of the wipeout. If you are operating high-risk cases in which suppose suprachoroidals are at risk or some hypotony maculopathy is likely to be there, and if you are doing a combined cataract procedure, because when you do a cataract along with a glaucoma procedure, the patients have that expectation that the vision is going to improve. Second is, once they're done with cataract, they assume that the glaucoma is also cured and all things are done with, which is not the case. We have to explain and document that the follow-up and monitoring and treatment for glaucoma needs to be continued. And of course, the risk of failure, if you are doing a combined procedure, would be much more than you would be doing a single procedure. So all those risks have to be explained as well as documented. Again, we have to be very, very cautious if we are planning for any kind of a premium IOL in these glaucoma patients, because the risks of dissatisfaction and complaints are likely to be much more. The records should specifically include the preoperative status, what was the IOP, what was the target IOP expected, disc photographs should be there. If photographs not, at least the drawings should be there, perimetry records, OCT records, etc. The progression, if it is there, it should be documented clearly. Intraoperative surgical notes, whether MMC was used or any device or implant was used, if any complications occurred during the surgery, what steps were taken, and post-op also, what is the follow-up advice that you give. If the patient is not compliant with those advices, again, you have to mention that this follow-up was advised, but the patient has not come on that date. If post-op complications occur, they should be documented, timely management of complications and referrals. And whatever we counsel to the patient, each thing has to be entered into the record. This is all what we have agreed from that no document means no evidence of the thing being done. Let's see some scenarios. Suppose this is the litigation scenario of TRAB failure. So what would be the allegation? That the surgery was ineffective, the surgery has failed, and the patient continues to have vision loss. The medical legal issues can be, was the surgery actually indicated? Was it necessary? Was the risk of failure explained to the patient? And was timely reintervention advised and done to prevent that failure? So our defense would be in documenting and having a evidence-based justified indication that yes, TRAB was necessary for so and so reason, a proper consent mentioning the failure, the risks for failure and all those things, and that we have taken adequate perioperative precautions and done a management to prevent that failure or treat those early failure cases. A second scenario, a wipeout phenomenon. So allegation would be that post-surgery, there has been a sudden irreversible vision loss. So in these, the medical legal issues would be about advanced glaucomas and one-eyed patients losing their vision and whether there was adequacy of this risk disclosure. Here, our defense would be, had we taken an enhanced consent for these special and high-risk cases, Was there an adequate counseling regarding that wipeout, and was it documented? And did we take adequate pre-operative, intraoperative, post-operative precautions? Like maybe the pre-operative IOP was kept low, mannitol was given, intraoperatively paracentesis was done, and post-operative or releasable sutures taken, post-op monitoring of the IOP. Did we take all those precautions to prevent that wipeout? Third scenario, maybe a tube exposure, so leading to infection and vision loss. So medical legal issues could be regarding the surgical technique, regarding your competency for doing that surgery, and was the post-op follow-up and care adequate and effective enough or not. So in this case, again, our defense would be documentation of an appropriate surgical method, timely detection of that complication and management, and if there were any factors related to patient compliance, like the patient splashing with water, or rubbing vigorously, or non-compliant with the follow-up or treatment, was that recorded or not? All these will be in our favor. So what are our risk reduction strategies? One is our consent forms need to be structured and customized. The standard surgical protocols and checklists need to be followed and very clearly documented. Any complication, it has to have timely recognition, management, and appropriate referrals if the need be. And our decisions need to be evidence-based, and we should also be aware of the continuous medical legal changes that are happening around us. So the key take-home messages as far as glaucoma surgeries are concerned: glaucoma surgery is definitely legally high risk, but it is defensible. Good indication with a good documentation and good consent are equivalent to good protection. Complications are acceptable, but negligence is definitely not. And professional conduct and ethical practice will be your best legal safeguards. Thank you.
Thank you, ma'am.
Very wonderful for saying.
Of new points, particularly related to the glaucoma. As we know, these are the diseases which are the silent theft of the disease vision. For these comments, I would like to invite Mohita Sharma, ma'am, to please say a few words.
Thank you, Dr. Deepak. Now, Dr. Purvi has already covered everything very, very well. Now, when we are talking of all these diseases, and when we are talking about medical legal issues, I think glaucoma becomes one of the very important diseases, especially because this is a disease which is blinding, and this is a disease where there can be an irreversible loss of vision. And generally, now we have been talking so much about documentation, consent, etc. Here it becomes, I would say, even more important, because we are carrying out these surgeries in only two conditions, generally in two conditions. Two indications are there. One is when there is a progression despite the treatment, and secondly, when there is a non-compliance. So both these things, when there is a progression, and secondly, when there is a non-compliance, both these things, for both, documentation is the most important thing. And in documentation also, what all investigations you carried out is important. Now, if you look at some of the cases or some of the litigations that have happened, a few times it has also been seen that in the investigations, less number of investigations probably were performed, where only based on pressure there was a documentation, where maybe OCT was carried out, but perimetry was missed out. Now, in an attempt to be what we call ourselves as ethical and not over-investigating the patient, we tend to advise less investigations to our follow-up patients. When we do that, as Dr. Subhash had also pointed out, in the court of law, we do not have any defense for why we did not do that investigation. So in this progression, there has to be a standard of care that this is how we are going to document the progression with these investigations, and then only come to a conclusion about surgery. That is one. Secondly, those cases which are taken up for surgery are generally very advanced cases. These are advanced cases of glaucoma. They are not early or early cases of glaucoma. Since they are already advanced cases, the visual prognosis, one is we are not expecting any visual gain. And secondly, despite the surgery may not be always successful, or it may be partly successful. Despite that, we may find that our result is not what we wanted in the long term. So our chair time here in taking consent has to be more. Maybe I would say, if it's a glaucoma surgery, instead of getting the consent signed on the same day, as we were discussing, it would be a better idea to spend some chair time with the patient 1 or 2 days in advance, explain everything, and let the patient sign the consent. So it cannot be taken taken like a cataract consent because every glaucoma surgery is a high risk case. So it has to be taken in a little different manner, where more time has to be spent, more time has to be given to the patient to come to a decision. The doctor came to the decision, but what about the patient? They have to also agree and give them time to agree to that. So rest, I think Dr. Purvi has covered everything very well, and so this becomes a very important disease as far as medical legal aspects are concerned.
Thank you, ma'am. So, Dr. Deves is there. Dr. Deves.
Yes, sir, I'm here.
So, since Dr. Deves in discussion, Dr. Vibhuti has to go somewhere. So there is slight change. I would request Dr. Deves Kumar to first finish his talk and Dr. Vibhuti to finish his comments. Dr. Deves,
Sure,
please.
Sure, sir, I'll share my slide.
I am available for the whole webinar, so you can call me anytime, Deepak, if you want.
Is my slide visible?
Sir, without you, it's not possible. So every time you have.
Yeah. Okay.
Is
Fine.
my slide visible?
It's Friday, sir, and many places PG teaching and other programs are going on.
So, but I am all the way idle, so you can call me whenever you want.
Thank you, sir. Thank you.
Shall I go, sir?
Yes. Please.
Okay.
Dr. Deves.
So at the outset, I would like to thank Team ARC for including me in this important webinar. So I'll be talking about clinical record keeping for retinal surgery. So I'll start with the published grounds for medico-legal cases pertaining to veterinary surgeons or litigations. Although these are from the West, but these are very relevant in our situation as well. So most importantly, it is the negligent surgery that is being claimed, or secondly, it is an informed consent issue. And in the negligent surgery, if we see, the claims are made against complications ranging from diplopia to increased floater after retinal surgery, prolonged mydriasis, decreased vision, need for more extensive surgeries. And in informed consents, these could be related to unrealistic visual expectations or assurances by the surgeon, or flying with intraocular gas. This is an important lawsuit that has these have been important lawsuits that have been there. Now, next is related to intravitreal injections, since these are the most common intraocular procedure being done nowadays. There are a lot of lawsuits that have come up regarding these as well, pertaining to injuries that happen because of irregular technique or contaminated injections leading to endophthalmitis, medication error, maybe the drug error or dosage error, and mismanagement of the complications. Now, you would all know this litigation, but although the court exonerated the ophthalmologist, but it still could defame the person or the institution. So it is always important that we give proper weightage to this part in our consent. Now, what are the different aspects which are different from other surgeries and retinal surgeries is that there is some irreversible vision loss that happens because of the underlying disease pathology, and you cannot attribute it to a negligent surgery later on. But that is what is being claimed in most of the litigations. Then you have to undergo multiple, the patient might have to undergo multiple interventions often, and the outcomes are not immediate. Unlike cataract surgery, the outcomes might be delayed for months to a year, and the prognosis, both the anatomical and functional prognosis, might be different, and it is often quite variable and unpredictable. That's why the retinal surgeries also become high medical legal risk surgery. And also retinal surgeons could also be involved in litigations because of being included along with other ophthalmologists, such as after a complicated cataract surgery with a dropped nucleus, or a complicated cataract surgery with retinal detachment occurring later on. And despite being done best from the retinal surgeons, they may be together involved in the lawsuit. Now, preoperative findings that are similar to all other surgeries, but you need to inquire about any disability of the patient. Now, this is very important. If the patient is disabled, has any disability, cannot take up positioning, and you have totally omitted that, and later on after the surgery, you say that you have to take this position and the patient can't take that position, and now the patient knows that it is important to take this position but can't take because it was not explained, so that becomes a very valid ground for litigation. Now, residence, whether the patient lives far off and because the patient might have to travel and may not take position again, or because the patient might be in high altitude and could and wish to travel by air, then you need to explain them accordingly. Now, in the preoperative workup, other than the usual workup, lens status and extraocular motility are very important here, because often cataract will progress after vitrectomy, and you need to very clearly mention about the lens status preoperatively as well as explain to the patient. Extraocular motility, since there have been litigations against development of diplopia in patients after buckling surgeries. So it is important that you note the ocular alignment before surgery. Some of these patients might have chronic RD, may have any sensory squint as well. So document that the patient has sensory exotropia or esotropia, and so that you are safe later on. And it's always better that you have a fundus photo of your patients at baseline and as well as on follow-up. If it is not possible, then do make a RD chart, keep it along with your clinical records, and the RD chart also needs to be well labeled. In case you don't have fundus photos, then you need a labeled RD chart. Other investigations that might be required are OCT to just prove that it was a macula of detachment or macular involving TRD, and ultrasonography in patients in which there is vitreous hemorrhage to document the underlying retinal conditions, and FFA if you want to document any ischemic maculopathy so that the prognosis could be explained later on. Now, you should document any diagnostic uncertainty which might be there. If the diagnosis is not clear and you still want to go ahead with the surgery, mention that the diagnosis is not clear and more information might be available intraoperatively or postoperatively when you do further investigations. Now, there are certain special situations such as RD cases. You need to mention that the macular status, was it attached, detached preoperatively, whether it is fresh or old, is it total or quadrantic, what is the PVR grading. If you just mention there is RD in this eye and you operate, and then later on in the postoperative period you have a poor outcome, and then you explain it to the patient, but there is nothing mentioned in the preoperative card about whether the RD was fresh or whether the macula was involved and what was the PVR grading. And if suppose you have mentioned it already, then that acts as a safeguard for you. Then proliferative retinopathy cases, mostly proliferative diabetic retinopathy cases, you need to mention about the duration of vitreous hemorrhage or TRD, the density or the height of TRD, and location, whether the macula is involved or not, and whether ischemic optic neuropathy or ischemic maculopathy is there. You document them and then operate them, because unless you have documented and the visual outcomes are not good, then that could be a ground for a potential case. Now, macular holes or macular surface procedure, again, because the patients often do have a fairly good visual acuity, and so you need to be very careful in these cases especially. And the duration of symptoms should be clearly mentioned, because that will be a prognostic factor, and hole characteristics and other concurrent pathologies which might be there, which might often be missed also, you need to mention them. Now, the plan of management should be clearly described in your clinical records, that this is the diagnosis or indication for surgery, and this is the whole procedure that is being planned. You should also mention the timing of the management, because it is of importance over here in retinal surgery, whether it is an emergent surgery that is required or it's an elective surgery. Emergent, if there's a giant retinal tear or there's a macula on detachment, then you need to take the patient emergently for surgery. Mention the uncertainty. If you are not certain of the plan, whether after clearing the media you would encounter a retinal detachment which is not very obvious on ultrasound, then you just take a consent for VR surgery as well, that it might be needed, and the tamponade accordingly. You should also mention that it is very uncertain at this point in time and you might need any of these. Now, counseling and consent, what is different over here is, again, the prognosis, anatomical and functional outcomes, they have to be properly mentioned in the consent form. Delayed outcome is very important. That is very different over here. So you need to mention that. Need for repeat interventions, resurgeries, and especially resurgeries will be required when silicone oil is being put. So that is you need to necessarily put that in your consent. Complications, not only the intraoperative and short-term complications, but long-term complications such as glaucoma, corneal decompensation, and cataract should be very well mentioned in the consent form. Now, it is also important that you mention that there may be restrictions related to the lifestyle of the patient, such as the positioning may be required after the surgery, which may limit the day-to-day activity of the patient, and the travel might also be affected if the patient. Then you need to mention the restriction related to travel as well, that the patient cannot fly by air till the time intraocular gas is there, and cannot travel to other high altitude regions as well. Now, informed refusal is also very important, like the informed consent. And if the patient, you should mention that if the patient doesn't seem to be very keen on getting the surgery, then you document that if the surgery is not done, then what can go wrong, or if it is delayed, then what can go wrong. So these are the informed consents in ophthalmology that Dr. Namrata Sharma ma'am has already highlighted, and one can visit them. So I'll quickly like to mention that intravitreal injections are the most common intraocular procedures, and you should clearly mention in your consent form that multiple injections might be required, and it is not for improving the vision per se, but for preventing any further vision loss. And any off-label use should also be highlighted, such as with Avastin or any other biosimilar. You should clearly mention the off-label use and explain it to the patient. The operative notes, you should include some crucial findings. Suppose there is a media clearing vitrectomy, so you should mention that what was the status of the retina in the intraoperative period, and the disc, and if there was any gross ischemia which was there. Beware, you should have some correlation with the preoperative finding. You can't just mention that there was an intraoperative retinal detachment that was noted after clearing vitreous hemorrhage, when you have already mentioned that the ultrasound shows just vitreous hemorrhage with no RD. And then any deviation from the planned surgery, whichever deviation is there, you should mention it, and mention the rationale also. Suppose if the traction could not be relieved and therefore oil was put instead of gas, do mention it. If there is any complication, do mention that complication happened and that's why oil was being used. Suppose there is a scleral thinning which is noted while doing scleral buckling. Now you cannot proceed with the scleral buckling, so you mention it that this scleral thinning is noted, or a needle perforation has happened, and that's why VR surgery was done. The complications should never be concealed, and you should mention all the complications, and also mention that the management that is done for those complications. Post-operative advice, other than the routine advice, you should clearly mention the positioning that is to be taken by the patient. It is always important that beforehand, before the surgery, you should demonstrate the positioning to the patient that this is the correct way. And in the post-operative advice, you need to mention the duration of the positioning as well. Now, travel, I have already touched that the duration of travel, and then the restrictions related to travel when intraocular gas is being used should be clearly highlighted. On follow-up, it is important that you document any missed visit. If there is any missed visit, do document it that the patient was supposed to come but did not come, because often these patients might have secondary glaucoma developing later on, or might have redetachments in cases of retinal detachments, or rebleeds, and if the patient doesn't turn up at the desired visit, there could be further complications. Document any deviation from the expected behavior that is expected from the patient, such as the positioning was not taken, or hygiene was poor, or medications not used or overused. Do document them in your clinical records. Other than that, these are the routine that you would do in any of your surgeries. The tamponade positioning again should be highlighted in the follow-up as well. Any warning signs such as sudden decrease in vision that might happen, or pain, should be told to the patient. And fundus photography, if required, if possible, you should keep fundus photographs to support your clinical findings. If you have an unfavorable outcome, such as a rebleed which has happened after diabetic vitrectomy, or a detachment happens after PPV, or a redetachment happens, do recognize it early, document it early, discuss with the patient, document that you have discussed with the patient, and plan further management timely. So to conclude, although good medical practices are expected out of all of us, but these are not usually enough. And regarding the retinal surgeries, one need to discuss and document everything in their consent, the diagnosis, the management, uncertainty in the outcomes, need for multiple interventions, especially in retinal surgeries, and the unpredictable outcomes. Thank you.
Thank you, Dr. Devesh, for giving us new thought on the retinal disease and their consent. Dr. Vibhuti Kashyap, would you like to add something or comment on the
Yes, sir.
Dr. Devesh talk?
Yes, sir. Good evening, sir. Sir, first of all, it was an excellent presentation by Devesh. I would like to add 5 things, 2 examples and 3 tips from my own private practice experience. Am I audible? I'm just not too sure about the network.
Yes, sir. You're
Clearly audible, sir. You can please.
I'm going to quickly run through those. So first example is that of a patient who underwent a VR surgery and who developed an endophthalmitis post VR surgery with complaints pertaining to endophthalmitis development that the patient developed on the 6th day. And the reason was the unsterile post-operative practices, which the patient acknowledged duly at the time of presentation, which was duly documented. The smart thing done by the ophthalmologist was to get the patient sign in the language the prescription was written in, so that they cannot refute later on. The patient did later on go on and file a case of negligence because the vision did not come back, and there the signature of the patient proved to be a clincher, where the patient was told that this was told to you and you agreed and this was mentioned. So it's always prudent in such dicey cases to have the signature of the patient on the prescription in the language that the prescription is in. That is one. Second, the importance of a fundus photograph. I was one of the legal scientific experts in one of the cases where I was being presented from the defendant side. So the patient underwent a cataract surgery, and the patient had intraoperative nucleus drop. And after the nucleus drop, the patient underwent SFIOL. And after the SFIOL, the patient did not gain vision, for which the retina surgeon as well as the cataract surgeon was booked. The patient, interestingly and unfortunately, expired during the case hearing when the date could come. So the patient was then no longer there to present himself, and the court was presuming that because the vision hasn't come back, it's the fault of both the surgeons. Luckily, in retrospect, in one of the scans, the patient had the OCT done, which had the fundus photograph along with it, which clearly showed some diabetic retinopathy changes of the severe NPDR types. So that incidental finding of us finding that photograph in the records proved to be a clincher in trying getting both the doctors bailout. So that was coincidental that on one routine OCT, the patient in one of the visits, the patient got the OCT done. But that just signifies how important it is to have the fundus photography, even in some innocuous looking cases where you may not feel like fundus photography is required. This holds true for retina specialists. Third tip is we should always try to aim at treating the patient and not the disease. Sometimes it may backfire. In one of the cases, the patient was treated with a VR surgery with gas, touted by many, including myself, as a superior alternative to silicone oil. But that caused a delayed outcome in the vision. And that was the reason for patient filing the case, because the patient said, I wanted an immediate resuscitation of vision or a reduced time interval before which I could gain the vision. The patient had to ultimately come, get the oil removed, get the gas evacuated and replace it with the silicone oil to have some kind of ambulatory visual rehabilitation. So even though we may feel that gas is superior, oil injection may be favorable more from the patient's perspective. And the last thing, whenever we do an ultrasound or any kind of investigation where the findings are equivocal, we should try and err towards making a report which gives you a more grievous report, rather than trying to sound all hunky-dory. Say a patient is having a vitreous hemorrhage in a diabetic case, and the patient is having that vitreous hemorrhage along with a subhyaloid hemorrhage with a strand. which an expert can say, okay, it's a thick hyaloid, but there is no harm in writing a query RD, a query retinal detachment over there, because you never know how the retina may behave in a difficult case where you cannot see the macula, you cannot see the retina, you don't know the fibrovascular proliferative status. You may end up having a nitrogenic break, you may end up having, subretinal bleed trying to, correct the fibrovascular proliferation. So always try to err towards a more grievous equivocal finding than trying to be more objective about it. I think that's about it.
Thank you, Dr. Vibhuti, for your comments. Since next talk was by Dr. Aarti, but somehow she's unable to present, Dr. Dipanshu will present her talk. Dr. Dipanshu?
Yes, sir. I'm here.
Dr. Dipanshu will cover the medico-legal aspect, and Dr. Satjit Sinha sir will give his expert comments on that. Dr. Dipanshu, please.
Am I audible and visible?
Yes.
Yeah, thank you. So, good evening, everyone. Thank you, AOS and ARC. Actually, also thanks to Dr. Aarti for giving me this talk. She could not present it due to some personal unavoidable circumstances at the last moment. I'll be speaking on medical legal aspects related to ocular trauma surgery. So, whenever a patient present to you with an ocular trauma, it's very important to assess the nature of the ocular trauma. It can be an accidental injury, it can be assault-related injury, it could be due to industrial exposure or occupational hazard. It could be secondary to sports injury, and also a very common during festivities, which we see is firecracker or domestic injury. So these cases may involve police reporting, compensation claims which can ask for compensation, disability assessment has to be done, and also there can be lawsuit or litigations for negligence against the doctors. So what are the duties of a treating ophthalmologist whenever they are dealing with cases of ocular trauma? Prompt examination and stabilization of the patient is important to begin with. Timely referral is important once you have identified the case and you know that there is less expertise available or the facilities are inadequate to treat the case. If you're treating the case, then adherence to standard accepted protocols is a must. A failure to adhere to these protocols may lead to medical negligence. The most important part, which all the speakers have previously spoken about, is documentation. That also plays a critical role, especially in cases with ocular trauma, because this is the most critical safeguard whenever there is a lawsuit filed against the treating ophthalmologist. Proper documentation is the strongest defense in medical legal cases, especially in ocular trauma. While you're examining an ocular trauma case, it should and must include the date and time of injury of presentation, alleged history in patient's own words regarding the how the injury has occurred. Visual acuity has to be documented bilaterally so that you can compare it on follow-up as well, and documentation is important. Detailed evaluation of anterior and posterior segment findings. There should be anterior segment imaging, and as also discussed in the previous talk, fundus imaging if possible, and if it is not possible, then B scan should be done in cases wherever possible. If it's a closed globe injury and media is not clear, then B scan is a must. And if it is an open globe injury, wherever possible, you should do a B scan if possible. Fundus imaging is also very important. If you suspect intraocular foreign body or an orbital fracture, then X-ray, CT scan, and USG scan is important and should be done as and when required. A provisional and final diagnosis has to be made, and this treatment plan and timing of surgery, follow-up visits, post-operative course, and complications should be explained in detail to the patient as well as to the attendant. And this should be documented as well in your file. It should also explain if it's an open globe injury, risk of endophthalmitis, development of retinal detachment, phthisis. Even if you are not expecting it, should be documented in your file so that it saves you in follow-up visits if it occurs. Next important is importance of informed consent that we have been talking about. Characteristic of a valid consent includes it should be an informed, voluntary written consent in patient's own understandable language. It must mention the nature of injury, the seriousness, which is the seriousness of the injury with which it has occurred. Poor or guarded visual prognosis has to be clearly explained. Possible complications that may arise due to the trauma or due to the surgery should also be explained to the patient in detail, be it endophthalmitis, be it retinal detachment or phthisis bulbi, and also the possibility of need for multiple surgeries should be explained to the patient. Patient should also, an attendant should be made aware of the risk of permanent vision loss or blindness in the primary sitting as well. Anesthesia related risk should also be explained to the patient, especially in cases where the patient is a minor. And since we were talking about informed consents and video consent, high risk consent is very important in patients with severe ocular trauma. If you have to then regarding the emergency surgery and consent in patients with life or severe eye saving emergencies, surgery can be performed under an implied consent, but that should be documented that the surgery was an emergency and delayed would have worsened the prognosis. All these points should be mentioned in cases where implied consent is being taken. If for an ophthalmologist, it is very important to handle these medical legal cases if the need arises, and what all points one needs to be taken care of are when to register a medical legal case, especially in cases where there is an assault history given by the patients who have arrived after a road traffic accident or after an occupational or industrial injury. Firearm or explosive injury should be registered as an MLC case as specific, and also in cases where you're not sure of the nature of injury, suspicious case or unexplained injury should also be documented as an MLC. The role of doctor is here in such case scenarios is to provide treatment without delay, inform policemen as per the hospital protocol, and maintain neutrality. Do not give opinions beyond the medical facts. If in ocular trauma, the common scenarios which might arise and which can lead to medical negligence or point out towards medical negligence are delay in primary repair. The patient is presented to you today and you have taken 3-4 days to operate the patient. That could be a common point for towards the allegation of medical negligence. Failure to detect an open globe injury. You have missed out, you have suspected, but you have not documented the intraocular foreign body. You have missed out during the primary repair. Improper surgical technique which might have caused more trauma than the actual trauma that has occurred to the patient during the ocular trauma, and poor post-operative monitoring and inadequate referral. So these are the few pointers which one should avoid in order to avoid the point of medical negligence in cases with ocular trauma. Whenever you feel the patient has recovered completely or the maximum output has been achieved following ocular trauma intervention, then only a visual disability certification should be issued, not before that, and it should be issued as per the national guidelines, and incorrect certification can lead to legal consequences. So apart from treatment documentation, ophthalmologists are often asked to represent the case in court of law whenever they have treated a case. So they may be called as a treating doctor, medical expert. One should strictly stick to the medical facts, records, and one should avoid speculative statement in the court of law. How can we reduce the risk whenever we deal with ocular trauma cases? These points are being highlighted in every talk, and one should have a meticulous documentation. Communication has to be thorough. You should always under promise in such cases, specifically in ocular trauma. You have to present the worst scenario. So after that, whatever may be the positive outcome, patient is usually happy with that as well. Realistic prognosis from the beginning should be explained. If you are not well equipped with managing ocular trauma, timely referral is important. And regular follow-up notes. Every visit, vision has to be documented. Intraocular pressure has to be documented. Wherever possible, imaging has to be done so that whenever required, that can be presented in court of law. And also the last and very important point of this slide is having a good indemnity cover in today's scenario. A minimum of 1 CR is what is recommended from Indian Ophthalmology. So for my talk, the key take-home points are in cases with ocular trauma surgery, good documentation, proper consent and adherence to standard care are more important medico-legally than achieving the good final visual outcome. I would like to acknowledge Dr. Anand Deshpande, sir, the head of AIS Medical Committee, Dr. Aarti Heda for giving me this talk, and Dr. Kaushik Tripathi as well for the wonderful talk. Thank you for your kind attention.
Thank you, Dr. Deepanshu. Now I would like to invite Dr. Satjit Sinha, sir. He's having vast experience on both and doing the trauma cases as well as the lot of such type of things. He's involved in saving other ophthalmologists also from the Bihar and other parts of the India. Dr. Satjit Bose,
Thank you, Dr.
wisdom.
Deepak. Wonderful presentation, Dr. Deepanshu. Even though it was given to you last minute, you did a very good job with it. I would like to thank Dr. Prashant Bhawankule, ARC Chairman, and Dr. Deepak Mishra, especially for giving me this opportunity today. It's very, very important to remember that these patients, all the other diseases that we discussed, they are already suffering from something, and then they go and get a procedure done, and then something happens out of that, and then the case goes on. But in these ocular trauma cases, just until recently, maybe the same day or maybe just 1 hour before, the patient had 6/6 vision, and suddenly he has lost all vision. So his expectation is huge, and he expects full recovery. Now, it's very important, like Dr. Deepanshu said, that we have to mention the time at which the injury happened, at the time it was presented to us. Sometimes from the village, they come after 2 days, sometimes they come immediately. It's very important to note the time. And as the patient comes, it's very important to take a full picture of the eye and make a slit lamp documentation. That is very important, that at the time how the eye was looking. Now, it's also important that, if possible, the pressure recording and gonioscopy records, as Dr. Deepanshu was saying, have to be kept. And very importantly, we have to tell the patient about these later things which happen, like sympathetic ophthalmia, which sometimes the patient is totally unaware of, and after it can happen after a year or 2 years, like sir was saying. So we have to tell that patient to come for regular follow-up. That is very, very important. And as was said by the earlier speaker, if the patient does not come for regular follow-up, that should also be documented, that the patient was called and he did not turn up. Also, subluxation of lens can happen later. And traumatic cataract is something which we have to inform the patient that even though everything is all right now, but sooner or later traumatic cataract may or may not happen. And that is something for which the patient should be prepared for. Proper record keeping is also very important. In these cases, I would definitely suggest that a video recording has to be done. It's not possible for the mass cataract surgeries that we are doing to do a video recording every day. But for these patients who come with ocular trauma, a definite consent of all the informed things has to be done, a video recording. And always give a guarded prognosis to these patients. Never reassure that you will be totally all right. And if your colleague has done something before you, always tell the patient that this was the best that could be done at that time, and never say that what that colleague may have done may not be the right thing. You always have to be in support of your colleague. And as Dr. Deepanshu said, informing the police, the local thana, is very important in these cases. And MLC form should always be there in your hospital to inform the local thana that such a thing has happened. Because sooner or later, it's always big, because these ocular traumas are happening because of fight between two people or between two children. And it is always going to go to the court, even if it's not going to going for against the doctor. It is between two people, and at some point of time, the doctor will be called. So the proper documentation is very important. But very well presented, Dr. Deepanshu. And thank you once again, Dr. Deepak, for the wonderful topics, and to Dr. Prashant Bhawankule for this wonderful assembly of all the talks. Thank you so much.
Thank you, sir.
Dr. Deepak, I would like to add one point.
Yes, sir, please.
Yeah, so it was excellent presentation by Dr. Deepanshu, and the comments by Dr. Satyajit were excellent. Only thing is, in most of the cases, and specifically these work-related traumas, most of the time the employer, they come with the patients and they say it is because of it is not related to that, so we must send these patients to the police, and they must write that whether they want MLC or don't want MLC, because later on the patient might retract from the statement that it was due to the work-related industrial work-related trauma, and then they might blame the doctor. So that is very important point.
Okay, sir. Very true, sir. So next talk is the medical legal aspect on the cornea, and somehow Dr. Seren is stuck somewhere, so she sent her video. Admin, please play her talk.
Are you there? Are you going to play the video? Admin? Deepak sir, I think nobody is responding. Deepak sir, are you there? I think there's a technical glitch. Meanwhile, if Dr. Kamaljeet Singh sir, if he can give a comment or two on the talk.
The previous talk was very interesting, and the trauma is a very, very big problem. And at the outset, I always tell them to write in the consent that multiple surgery would be required in this case. And prognosis wise, they have already told that the prognosis should be guarded. But three important things in the overall scenario I would always talk to my students is that 3 P's should be in your mind. These are warning signs. One is a politician coming to you for treatment. The other is a prosecutor. And third is a policeman. So these 3 P should be kept in your mind. And I always put a circle in my prescription, because they are very, very dangerous people for the doctors. And they always blame you, and they unnecessarily they would like to indict you for these problems. The CPA is mostly in Allahabad, at least we have lots and lots of advocates, and every patient is almost an advocate. So we have seen that many of these cases, they go to the court. Despite having, even if watering is there, they would complain and they would go to the court, because for them it's free and for you it's a trouble.
Definitely.
So these 3 things have to be kept in mind. That's all.
Yes, sir.
I would say.
Very important points. And also one thing which I usually mention in my notes is that the aim of primary surgery, specifically in open globe injury, is to maintain the globe architecture or the anatomy of the globe.
Yes.
Visual outcome and functional outcome is a secondary objective usually in these cases.
Sunil, kindly play the talk of Madam Dr. Seren ma'am. Admin.
Sir, I'm here. Tell me.
Yeah.
Can you play the video of Dr. Sharon D'Souza?
Yes, sir. Just a
Thank you.
And Dr. Rajesh Joshi from the Nagpur will discuss on this.
Yes, sir.
Dr.
Yes,
Rajesh.
definitely. Yes.
Yes, boss.
Yes, sir. Thank you so much.
Hello, everyone. At the outset, I would like to thank AIOS and ARC for this opportunity to be a part of this wonderful webinar and speak on such a relevant topic. Today, I'll be speaking on the medical legal aspects of corneal transplantation. So many of us may be in one of these 4 situations related to medical legal issues, either having previously received a complaint, or we are just concerned seeing how situations develop for other doctors, or we may not know any of the situations but would like to know more. So why is keratoplasty so medico-legally sensitive? This is because even though it's an elective surgery, it is a very high expectation surgery. We are often dealing with patients where we are trying to restore vision or a very severe infection which needs to be controlled. And the outcomes depend on multiple factors, one of which is patient compliance, because these cases require a very long-term follow-up. And as we know from experience, once there's a long-term follow-up, it is more difficult for the patient to be compliant or follow up with their medications. The long-term follow-up also implies that there's a prolonged liability on the doctor in case anything goes wrong in that follow-up period. What is very important to remember is that graft failure is not equal to negligence, even though it is often perceived so. So where do things go wrong? There are a number of high risk phases where there can be a high legal risk. One of them being the preoperative counseling, which is very, very important in such cases where we can try to explain as much about the surgery, follow-up, prognosis as possible. The informed consent is an extremely important point, and we'll be going into that in more detail. The intraoperative surgical management and of course the post-operative follow-up are high-risk areas, and complication management. So there are a number of common allegations which may happen around a keratoplasty, one being the poor visual outcome, if there is graft failure or rejection, post-operative infections. Some things which are really grievous is a wrong indication or a wrong eye being operated, inadequate consents, of course, and a delay in diagnosing complications. So let's have a reality check. Does the graft failure automatically imply negligence? So that's not true. The court assesses the standard of care, not the actual outcome. And as long as we can show that the standard of care was followed, it would still be in our favor. Now, informed consent is our strongest shield, and I have just shown some snapshots of a consent form. This is actually the consent form which has been shared by AIOS for all its members, and it's a very comprehensive consent form. So the consent must include indications for surgery, the type of keratoplasty, because in corneal transplants we have so many different kinds, so it has to be specific. If any alternatives were explained, including no surgery, the risk of failure, rejection, repeat grafts, and as many of the complications that we can list, and the need for long-term follow-up requirement is also very important. Again, the signature has to be by the patient. If the patient is a minor or not able to take a decision, then it has to be their guardian. Witnesses are advisable to have signed it, and the declaration by a doctor and the signature by the doctor. If you have a very long consent form with multiple pages, it's advisable to have initialing by the patient on every page so that they may not say that they were only asked to sign the last page and were not aware what was there on the previous pages. So what courts expect in a consent is that it should be procedure specific, not generic. It should be an understandable language, and most consents have this line right at the beginning or at the end that the patient was explained in a language fully understood by them. Documented counseling is very, very important. So if you have a high-risk case and you want to do a video counseling, video recording, that would be good. It should be signed before surgery. So even in a busy schedule, please don't forget to do this before surgery. It's timed and dated, and witness signature is preferable. If you want, you can have consents in the local language or multiple languages. That is also very, very useful. Since we are dealing with corneal transplantation, there are a number of issues which happen with donor cornea or eye bank. So these are our medico-legal responsibilities on this aspect. One is that we should be taking the cornea from an accredited eye bank with proper documentation. All accredited eye banks have EBAI guided work where they screen for various infectious diseases. So that should be mentioned as to what has been screened for on this tissue. The death to preservation time, the tissue grading and labeling should be very clear, and it should be traceable. In case of an issue, we should be able to go back and check any details about this patient. Since if you are a doctor who is using a tissue from an outside eye bank, then it's important to file all of these papers separately so that you can trace it back anytime in terms of whenever there is a problem. Unfortunately, you can have a donor-related infection, and this can be very tricky. The question is that who is legally responsible when something like this happens? Is it the surgeon, the eye bank, or both? What we must know that it is a shared responsibility between the eye bank and the surgeon. So it's very important to document. So if you do have a culture positive tissue like this, then it's important to document it and make sure that it is filed, so that in case it goes to court, then we know where the actual challenge arose. Surgical techniques, of course, have to be the standard of care. There are accepted techniques for every indication, and that has to be well documented, both in the clinical file, or if there are any adjunctive tests which are required, then they should be done. Adequate training of the surgeon, of course, is important. Use of standard equipment and instruments for the surgery. Intraoperative decisions must be documented. When it comes to instruments, of course, sterilization of these instruments, or if they are single use, all of this has to be documented very, very well. Any intraop decisions like conversion of a DALC to a penetrating keratoplasty must be documented in the intraoperative notes. And if there is a chance of this happening, then it's better to communicate this possibility to the patient prior to surgery, and can also have consent signed accordingly. So if two consents are required for two different procedures, better to get it signed before surgery to avoid any challenges after. But do remember, intraoperative complications do not mean that there has been negligence, and the court does accept this as well. Post-operative care, of course, there can be legal pitfalls if some complication is missed. If there was inadequate counseling for medications, patient has overused the steroid, but there is no way to prove that you had advised not to overuse. Poor follow-up advice, lack of documentation. So the key rule is that everything should be in writing. All oral communication should be written into the case sheet. For example, if you have advised steroid for an X duration followed, then it's better to follow it up by writing, then stop, or at least, very clearly mention the duration. Clear communication is essential. Even if there are complications, do not try to hide it. This could really help us in case of complications. So the most commonly litigated complication is an infection or missed rejection, but I must reassure you that it is not at all common for a transplant to reach a litigation. So please do not be scared. As the saying goes, if it's not written, it has not been done. So essential documentation includes that in the preoperative chart or the clinical chart, there would be an indication and the prognosis, the counseling details which have been done, the consent, the donor cornea details should be maintained. This includes having a corneal transplant register, tissue procurement register, transplant waiting list, and a folder with all relevant eye bank tissue and patient details for each case. Follow-up advice has to be mentioned in the documentation and clinical file. And in case the patient misses any visit records, then it's better when they do follow-up to make a note that they had missed their follow-up for X duration. Now, these are the legal principles which are relevant to the ophthalmologist. Of course, we may not know the entire in-depth details of the Protection Act, but one very important principle is the Bolam principle, which basically says that if the standard of care has been maintained by the doctor, then it is not a negligence on their part. And please remember that the burden of proof is on the complainant to prove that there was a negligence. So at least the law is on our side in that way. How to protect yourself? Always make sure there's the right indication, have a detailed consent, take the tissue from an accredited eye bank, use standard surgical techniques. If there's a complication, early management, excellent documentation, and clear communication at all points with the patient. From experience, I believe that we should try to under-promise, over-deliver. Any non-compliance has to be documented. Address the complications early. In case of any complications, stay empathetic. Hold the patient's hand through the entire process. Make sure that they feel supported through it, but we cannot be defensive about any such incident. Avoid casual WhatsApp advice, especially nowadays. Patients tend to ask for a lot of advice on WhatsApp. But in these cases, better to avoid anything without record, especially for any medications. So the take-home message is that keratoplasty as a surgery requires lifelong care. Good results, of course, reduce the risk, but good records is what prevents litigation. Communication is the best medical legal tool, and a good consent is our best armor. So with that, thank you very much for a patient listening.
Thank you, Dr. Saran, for the wonderful talk. Dr. Rajesh, first we will take comment from you, then we will go to the Tetial sir, who is almost the father for all the corneal surgeries. Dr. Rajesh.
Yeah. Thank you so much. I thank Dr. Prashant for giving me this opportunity, Dr. Deepak, Dr. Dipanshu, Dr. Lipi, and everyone. The key is to have a documentation. No documentation means no defense. That is very important thing. And most of the points have been well covered by Dr. Sharon. The counseling should start whenever the patient meets you, because every patient is a potential litigator. You never know who will file the suit. So what I do, I usually start on a OPD paper. Being in a government institute, we have to write everything handwritten. So it starts with in OPD itself that I have explained this thing to the patient. And particularly in these patients who are undergoing keratoplasty, you never know, because this patient may have multiple complications, multiple surgery. That has to be explained to the patient right away whenever you are taking the patient for the surgery, as well as it should be handwritten. We have such a typed consent form, but if something is going to go wrong, or we want to have some, we expect that some complications may occur, we usually write down on a paper that this thing is going to happen, and you may have to undergo repeated surgery. That has to be explained to the patient. And keratoplasty is not a one-time surgery. Patient may develop cataract later on, or may have glaucoma, retinal surgery. So this has to be explained to the patient. And one thing I want to add in the list of protection, that you should have indemnity policy to protect yourself, whether you are a government servant or whatever, private practitioner. You should have indemnity policy to protect, because that is, if something goes wrong later on in the court as well. So you have insurance company which will stand behind you. And I think everything should be written. That is important, because that stands in a court of law. And I think video consent and everything has been well explained by other speakers. So that is from my side.
Thank you, Dr. Rajesh. Professor Tetial sir, not on the PK, but I would like to take some comments from you on the refractive surgery too, because most of us learn by reading your book on the refractive surgery, SMILE and other thing. Sir, please guide us on this both topics.
Thank you, Deepak. I think the entire this webinar was beautifully covered. They covered almost every aspect of the pre-op, intra-op, post-op care, and the maintaining the records. Nicely highlighted. I appreciate that. I've learned so many things today. One thing which I have learned, I was in a teaching institution where we discuss the case in front of patient, and many things are talked about. Why not this? Why not that? Why your diagnosis is is not correct? Why have you not done this? You should have done this way. And that type of discussion, now I realize, should not be never done in front of patient, because they'll take it, or relative, they'll take it, okay, this something has gone wrong, and this is not done correctly. So this is one very important point. Nothing should be discussed in front of a patient and party regarding the various other aspects of doing the same thing. Or even in the keratoplasty, sometimes we say this suture is not correct. It's not radial. The depth is not proper. So those things are teaching purpose, but they take it in different manner.
Right.
And that is a very important aspect, which I have realized now. And as far as refractive surgery concerned, it's one of the most challenging area because we are doing a surgery in a normal anatomical eye, though it is for a correction. There also, because the understanding from patient and relatives are such, they think it would be 100% accurate. And that is what we have been talking here. Always, never overpromise to the patient for any surgery, and more true for a refractive surgery, where the patient's expectation is very, very high, and that should be also looked into correctly. And I normally now I talk to my optometrist who does the workup for initial patient, not to speak to a patient in any form, where they might promise, or your vision is 6/5, because they try to get the reward from the doctor. They done a good refraction and vision is 6/5, which never comes after refractive procedure. And sometimes even telling you'll get a supernatural vision or a eagle's vision, which should not be never be told to the patients in today's time. If they come out with these ideas because they read a lot of information in the nowadays Google internet, so we should be telling the correct or approach should be, okay, this is your vision. I tell them, after refractive surgery, you may not have a same contrast which you have with the glasses or contact lenses, because we are doing the interface management. Your contrast might take 6 months to come back. So these things should be told. And one thing we always have problem with the refractive surgery patient, they keep checking their two eyes. They say, doctor, one of my eye is not as good as the other eye. So this also has to be highlighted beforehand. You have a one dominant eye and one non-dominant eye, and that has to be clearly told to them. Two eyes will never be equal, and that's why God has created to have a better depth perception. If you tell them, the poster there, yes, doctor, you told me this. Otherwise, this is a major challenging question I face every time. Doctor, is 6/6, but I'm not, it's not equal. So that is one thing we have to highlight. And I think one thing which we miss is, whatever procedure we do, we don't, sometimes miss out in refractive surgery, the ocular surface examination. That now is my compulsory part for any refractive surgery procedure I do. The entire ocular surface analysis has to be done and documented. If you have a dry eye diagnostic equipment, do it so that you know that all the parameters are done. And I tell them this is what you have, and this might get accentuated, and treatment may be needed for a very, very long time. And normally I tell all refractive surgery patients the lubricating drop will be there more than a year or sometimes lifelong. So some things are very, very important, which we have been discussing. Proper explanation to the patient and party, what is the outcome we are going to achieve, and always make sure your other people speak in the same tone. Like you have optometrists, you have your colleagues, you have your counselors now. So they should be told that this is what I want. I think Dr. Lalit nicely pointed out, nowadays counselors are doing, all the, talking with the patient. Even the consents are taken by our, staff nurse. Sometimes we don't know what they have signed for. So you need to have a talk to these people. Okay, this is my way of counseling the patient. This is how I talk to the patient for multifocal. This is how I talk to my patient for monofocal. These are basic aspects the counselors should all know. And their training has to be done by the team, and ultimately you should be training them so that there's no difference in our way we talk. Otherwise, these patients will say, you said this, your counselor said this, and I was confused. So that point we also have to highlight, apart from the writing which we are doing. So it is our duty to make sure our staffs are at the same, you can say, stage of doing all those calibrations of delivering your outcome to the patient. I think otherwise beautifully covered, and I think medical record keeping has to be one of the most important points, and it should be discussed more often. If somebody can present their cases, how the case was implicated and how did they fought this case, and how was they could win or they lost and why, and those will be very interesting. We
Yes.
know that many
Absolutely.
people may not like to come out with their cases, But yes, if we have those examples, our younger generation will be more aware. And this, I think, should be given to all the resident doctors or fellows. They should be listening to this. They are very, very careless. They think they have come for a learning. It's not their duty to fill up these things. Why they have been burdened with these, documentation? They should be doing surgery. So that concept yet put in their mind, this is the thing you have to learn first. And then we'll be in a proper way. And
Right.
somebody pointed out, like policemen or people with, coat, you should be more careful. In fact, you should be 200% more careful with these patients, how you speak to them and how your body language should be also checked there. Never be too friendly with these people. They'll come as your friend, but these people, once they have some problem, they are no friend to you. So that has to be realized. We always think, okay, he's my friend, referred by my friend. I know this person, we have been friends for 10 years, 20 years, but if something goes wrong, they are the one who will be, because you take very lightly, but they'll take you in the court. I think these are few important things we should realize.
Thank you, sir, for the wonderful session. We will plan some
Dr. Deepak.
parts in future in which we have we connect some ophthalmologists who are really fought for such type of cases.
Yes.
And since we are at the end of the webinar, Dr. Subhash Dadia, sir, you are
Basically about the last talk.
your comments on it.
I wanted to say two things only. It was excellent talk and excellent comments by Dr. Rajesh Joshi.
Thank you, sir.
Every corneal surgeon, they must read Standards of Eye Banking in India, which is the book which is published by Ministry of Health, Government of India. And secondly, they must read the HOTA Act.
Yeah, absolutely. I do agree with it.
Kamaljeet Singh, sir. I think, sir.
I'll say one more thing here, what Rajesh was talking about. Your wherever you are doing surgery, that should be approved as a transplant center first. It's very important.
Yeah.
Second, you should have the your certificate with you that you have been trained in a corneal surgery.
Right.
That too very, very important. Otherwise, you will be in problem.
Right.
Basically, it is it comes under criminal liabilities, sir.
Yes.
After this HOTA Act.
सर सो गए क्या बोलिए कुछ
नहीं हम ये कह रहे
final comments.
हम ये कह रहे हैं कि भैया देखो उसको जब अगर एक ऑपरेशन करो ना तो उसको लास्ट तक जो है उसके साथ चलो।
बराबर है, बराबर।
और कई बार ऐसा होता है ना, कॉर्नियल डिकम्पनसेशन हो गया, अब आपने उसको भेज दिया किसी के पास, उसने जिसके पास भेजा उसने कह दिया ये कहाँ करा लिया यार, तो बिगाड़ ही दिया उसने, अब मैं कॉर्निया क्या करूं या कहाँ से लाऊं क्या लाऊं। तो आपको मतलब उसके साथ लगा, मतलब ये जिम्मेदारी परमानेंट हो जाती है। और अगर कोई गड़बड़ केस किया है तो उससे जब आए तो उससे बहुत ही प्यार से बोलो, उसको बताते रहो और प्यार से बोलते भी रहो, बहुत ज्यादा जरूरी है। उससे कोई आर्गुमेंट नहीं करना है, विच इज वेरी वेरी एसेंशियल। क्योंकि आर्गुमेंट होता है वो कहेगा कि नहीं दिखा, वो कोई तकलीफ भी बता रहा है तो आप तो अंदर से जान रहे हो मैंने गड़बड़ किया हुआ। लाइक आई टेल यू जस्ट वन एग्जांपल, देयर वाज वन ऑफ माय पेशेंट लॉन्ग टाइम बैक, आई डिड अ IOL and had a small PCR, there were vitreous floaters post operatively। तो वो रोज आता था, कहता था विजन 6/6 थी। तो जब आए मुझसे तो कहे कि सर वो काला काला मैनू दिखता, पंजाबी में बोलता था, मैनू काला काला दिखता, मच्छर उड़ते रहते ने। तो हमने कहा यार मैं क्या करूं, विजन तो ठीक है, पढ़वा देते थे उसको। लड़का आता था साथ में, तो एक दिन वो लड़का तंग आ गया ला ला के, तो हमने तो इतना पोलाइट रहे विजन 6/6 थी, तो बोला सर तुसी ना मच्छरदानी लगाओ, काले काले मच्छर उड़ रहे थे। आफ्टर दैट पेशेंट डिड नॉट कम। तो आपको बहुत पोलाइट रहना, और ये तो आपको मालूम ही रहता है कि गलती हमसे कहीं हो गई है, उसको सुधारना। अब जिसमें गलती नहीं हुई वो केस करता है तो फिर तो मजबूरी है। दैट इज ऑल फाइनली आई वुड लाइक टू से। थैंक यू।
थैंक यू सर।
गलती एक्सेप्ट करना है, दूसरा बंदा मान जाता है कि उन्होंने गलती एक्सेप्ट कर ली और काम सही कर दिया।
हाँ,
वेरी ट्रू।
लेकिन कोर्ट में उसी गलती को रगड़ देता है, आपने गलती एक्सेप्ट की थी तो मैं भुगतो।
At the end, from the whole team of AIOS ARC, we would like to thank our respected chairpersons, Tetial sir, Lalit Verma sir, Kamaljeet Singh sir, Subhash Dadia sir, for your presence and guidance on almost all and every talks, and wonderful talks by almost every speaker, and same level and quantity of the discussion by our discussant. And I can't thanks my co-moderators Dipanshu and Lipi, because in this is the one of the disadvantage also of this internet era, that sometimes you will be in, sometimes you will be out. But thank you Dipanshu and Lipi for helping me out whenever we are on the out of the network.
Thank you,
And
sir.
all the viewers and the IT team for supporting us with this. And the take home message from the Tetial sir, that we will plan some more webinars with actual cases and the actual facts. But these are the so much important that nowadays lot of consumer cases, and these are coming almost to every ophthalmologist.
Yes.
So we have to be more cautious on each and every aspect. And thank you, sir. Surely we will plan something better, and we will come again with folded hand request you all again to support us and give us such ideas in which we can do much better. Thank you, sir. Thank you, everyone.
Thank you, everyone. Good night.